irreversible pulpitis, very deep caries defect, ninja access, and direct restoration after endodontic treatment. This is our new clinical case. Hello dear colleagues, welcome back to BG Dental Cases. This time will be very interesting clinical situation, very non-standard, and I'm going to share with you some clinical tips and tricks how to deal with such cases when you have very deep caries defects and how can you preserve as much tooth structures as it possible. From the initial slide you can see deep distal defect and the necessity to do root canal treatment, and imagine if you will go for standard protocols of access formation, maybe you will be end up with no tooth at the end. The situation was pretty difficult as well, not just because of the deep decay, but also the adjacent tooth, the second premolar, that was not erupted completely, and we faced with difficulty to provide proper rubber dam isolation for endodontic treatment. So let's go. Before I will start explaining you step by step the case, I would like to ask you, don't forget to put likes and to sign up to our YouTube channel. Your likes will give us possibility also to spread the video all around the YouTube, and many colleagues will be able to see and to learn. So basically you will contribute into the dental education worldwide. Fine, okay, so this is our initial intraoral situation. You can see the second premolar that is not erupted and the isolation that we provided. Actually, we are not able to do classic isolation with normal single tooth isolation because we don't have possibility to invert our rubber dam between two premolars. So we decided to do split dam, okay? And then I will be showing you video, step-by-step procedure, how did we solve the problem with this deep caries defect, how did we manage the isolation of distal zone, and actually how we ended up with the clinical performance. So let us see, let's go, and this is the video and I will be commenting all the steps. So we made this split dam isolation. Split dam allowed us also to excavate caries, to make gingivectomy. In this case we had to because it was very deep. Here you can see the picture, the very deep, so actually the root surface. And when you have this root surface, you have to deal with soft tissues. Another thing that I would like to point your attention to is matrix. The standard matrices will be what actually they were. I tried many standard matrices and they were non-efficient because the level of soft tissues from vestibular and from lingual side were way higher than we had from the distal. So the difference was huge. I know that there are some specific matrices that they have this kind of extension, right? But this extension was not that deep as was necessary. So what I did, I just took metal band, I took my scissors, and I customized matrix according to the clinical situation that I had. And I was able to insert that matrix very deep to the root surface. So that was the tip number one. The tip number two is that we stabilized matrix with Teflon tape. There was no way to use wedge, because if I would use wedge there, the wedge will push my matrix inside the defect and we will have reverse or negative profile, negative emergent profile afterwards. So in this case it's better to do something different. So actually we took Teflon and we packed Teflon between adjacent tooth and matrix, and Teflon brought the matrix to the cervical area. The one thing also that I would like to say is that Teflon holds matrix not that efficient as wedge. So basically in that cases you will have to use soft materials to restore the wall. So you cannot pack heavily, otherwise your matrix will be detached. Another thing, here you can see additional isolation. I used light body from PVS just to close the gap and prevent leakage of the saliva during the process of treatment. So we had matrix, we had Teflon, we had this PVS material that helped us to make a prominent isolation. Here you can see access. Endodontic access was completely defect oriented. The problem with this access is that your files will go into the root canal in non-straight line mode. But if you deal with a very easy root canals, like in this case, actually we have type 1 root canal, which is straight and wide. So basically it was not difficult to solve the problem with instrumentation. And another problem is about pulp horns, and now I'm going to share with you tips and tricks related to that issue also. Regarding restoration, look what I did. Since we don't have possibility to packable composite, so we decided to do combined way of the restoration. We used flowable, highly filled flowable. We put this highly filled flowable like a drop or a few drops, and we didn't light cure it. Okay, and then immediately we took preheated composite, and gently we were able to pack it with a micro brush. So basically this technique will allow you to fill all the gaps with flowable and to create the main volume of the defect with packable composite. So we did it layer by layer. Since we have very deep defect, we have to work with layers. So one layer was placed to the lingual side, light cured, then you see the flowable, and we packed it with a normal one to the lingual, to the buccal side, light cured, and we were able to restore the whole wall later on. The trick also to fill pulp chamber, again the same thing, you just inject flowable and you pack it with a packable, so the flowable will be forced to the pulp, put to the pulp chamber. So this is layer by layer restoration, direct restoration. Since we have very small defect and we preserved tons of tooth structures, we were able to do direct composite restoration. So here you can see conservative endodontic treatment and also conservative restorative treatment. This case, by the way, was done in 2013, and I was experimenting actually with composite techniques. I used these, multiple layers, tried to sculpt the dentine. Also, I used tints. Nowadays, I don't use tints a lot. I can do proper layering technique and create these 3D effects without any tints. But anyways, I tried my best in all techniques that time. Even you can see that I put tint in dentine layer. Then I used a very thin enamel layer to make this, crazy fissures, secondary fissures or whatever. Now I can say, since I have experience with these conservative treatments and composite restorations as well, that composite has to be easy, has to be repeatable, and has to be also non-time consuming. And we have a protocol now. We have very simple protocols to work with direct composite materials. If I would have the same case now, I can rebuild dentine just a few layers, and the final layer of enamel will be done with this layering and making fissures with no small increments. By the way, if you are interested in this kind of stuff, using composite materials in your daily practice, we have very good, advanced, hands-on course about composites, and we teach not just direct composite restorations for posterior and anterior teeth. We teach composite restorations in daily basis, like direct, indirect, and semi-direct. For example, we teach how to use composite materials in copy-paste technique, in semi-direct technique in full mouth rehab cases. When you have wax-up from the dental technician in articulator, how can you transfer the wax-up into the patient mouth with a composite? Packable composite, not flowable. Packable that is strong. that it can keep occlusion. So this is what we also teach during this kind of course. Module 2, all about composites and rubidium isolation. The link you can find below this video, and we will be happy to see you here in Kiev, and we'll teach you all techniques with composites available that can make your life easy. So we ended up here with that result. Pretty natural looking restoration with slight tints, but again, nowadays I can do it without tints and pretty much the same result we can get. And few tips now for the case at all. So first, the minimal invasive access. I'm not very good supporter of such a ninja access in all cases, okay? Sometimes we have to, like in this case we had to do the conservative access, otherwise we will end up with destruction, like here. From the left picture you can see our access, from the right side just a simulation if we would do straight line, let's say. Again, we have to understand when and where we can do conservative access and why. Okay, that is important. What kind of root canals we have, what kind of problems we may expect, etc. So in such a case, when I had an easy root canal, I was able to do this kind of conservative access to preserve as much as I could. Okay, then the second problem is pulp horns. So the trick is, if you will use pre-curved or banded ultrasonic file, you can go deep into the chamber and you can clean the soft tissues like pulp mechanically and also with sodium hypochlorite. So we fill pulp chamber with a sodium hypochlorite, we took our banded file, it goes underneath pulp floor, okay, pulp chamber, sorry, and we can remove pulp tissues mechanically by ultrasound and also chemically by sodium hypochlorite. So that is the trick. Regarding the access, we discussed actually with you. The isolation you saw, split them, customized matrix, packed with Teflon, and then we just made this kind of fancy, nice looking isolation to prevent leakage of the saliva to our operating field. Here is the before and after endodontic treatment. You can see how we were able to create proper emergent profile and avoid overhang of composite. The final restoration, and we made afterwards orthodontic treatment. Here you can see sequence of orthodontic treatment from 2013 to 2018. Okay, and you can see, by the way, on 2018 the teeth, the rest of teeth were restored with composite, and actually we used this copy-paste technique. We used the stems from the wax up and restored all of her teeth because of the occlusion. Check on this, on her the first image, that molar teeth were worn and also incisors were slightly worn. So basically after orthodontic treatment we made some adjustments on occlusion, and we use composite materials in copy-paste technique. So module 2, the link to the course below the video. You will be our guests. We will be happy to teach you. Also, if you are interested in topic related to post-endodontic rehabilitations like fiber posts, core build-ups, overlay preparations after endodontic treatment, and crown preparations or after endodontic treatment, we offer you online masterclass. The link to this online masterclass you can also find below the video. And that's it. Don't forget to put likes, my friends, and to sign up to our YouTube channel. We will be more than happy to see more followers and also to share our knowledge with more people. Actually, I think that these kind of presentations and mini webinars, they're supposed to be helpful for many people, because usually we used to share that kind of cases during conferences and congresses where people have to pay money for, and now this is free. Okay, and what else? I would like to wish you all the best, to be healthy, and may the dental force be with you, my friends. See you next time. Bye bye.